this in the New Year season yet, because it feels like there's always that, let's circle back in the new year, and it's like,
Mm-hmm.
are we there yet? But I will say, I also feel like I've never been busier this week right before Christmas. Normally things get a little bit quieter, but there's been a lot of movement, it feels like, this year.
Same,
So I don't know.
same.
Hmm. But that's good. It means people are keeping busy.
That is good. Yeah. And I know that everybody says that we had a shorter time between Thanksgiving and Christmas this year. So maybe that
Yep.
adds to it. I don't know if I've ever paid attention though. I don't know if I've ever like counted how many days or weeks that we've
Yeah.
had.
Yeah.
My
You have
mom
two
probably
people.
does.
I was you just say you have two people. You have the people who are like, "Oh, I'm so ready for Christmas. Oh yeah, I've been ready for more." You know what I mean? And then you've got the people like I was brought into work clinically this week, and I asked both of my patients, "Are you ready for Christmas?" And both of them were like, "I have not bought a single gift yet." Like this is really So you got two different kinds of people there, and that cram time between things people is like so critical.
Mhm.
Um, we were at the mall yesterday doing the Christmas Angels thing. So, we picked a couple of kiddos and we bought some toys for them. And it's so funny. You can see all the men kind of panicking and running around the stores right now, like, which is early for them, I think, to be doing all their last minute shopping, but
Mhm.
gotta love it.
It's like the Walgreens on Valentine's Day, like the card
Yeah.
aisle. Kirk always jokes about that.
Yep. Yep. Get the stuffed animals and the chocolates going.
Exactly. Well, I know that a lot of people were here for part one a couple weeks ago, but I'd still like to read your
Yeah.
introduction here, and then we'll go ahead and get started. And like I said, everybody, welcome to our masterclass. We're so excited to have Katrina Sanders back. Please familiarize yourself with the chat area because that's where you're going to be able to ask questions later, and then that's where I'll provide the link to apply for your CE credits as well. So find that on Zoom. Heather says part one was phenomenal. Looking forward to today. So thanks for coming back. So Katrina is a vibrant, passionate, and charismatic award-winning educator with a unique approach to delivering continuing dental education. A distinguished speaker with many dental hygiene study clubs, Katrina's lectures incorporate a caring, comedic, and supportive style. She is passionate about educating, empowering, and instilling compassion within the dental hygiene industry. Katrina's zest for dental hygiene is infused throughout her content as she lectures on provocative topics while leaving participants with a call to action and an abundantly renewed sense of pride for their industry. With a glass of wine in hand, Katrina delivers a no-nonsense approach to challenging the dental profession while providing educational opportunities for the general public to better understand the importance around oral health. Most notably, her consulting, international speaking, podcasting, ghostwriting, vlogging, and educational profit centers have placed this wine-sipping ginger into a champagne bubble, bringing her to the top of her industry, and she wishes to share her top secrets to success with the world. So thank you, Katrina. We're so happy to have you. And I don't see your glass of wine this morning,
I know
so.
it's a little early, Angela. No, oh, thank you so much for that incredibly kind and warm introduction, Angela. And I want to begin by thanking all of you so much for being here. And I'm wearing my Christmas sweater today. It says Bah Humpug on it. So, for those of you who are animal lovers and dog lovers, sending lots of love to you. And of course, the pets around the holidays, right? If you're animals or anything like mine, they're very much looking forward to the toys and the treats that they're going to open up around the holidays very soon. So it's so wonderful to be here. Thank you so much for joining us this Friday for this masterclass. This is part two of the Hygiene Exam Essential series. So if you joined us 2 weeks ago, we walked through part one, which was focused around the assessment phase and how do we capture the opportunity to grab assessments that are going to help color the picture a little bit differently, particularly when it comes to explaining to our patients the display they may have in their mouth clinically around oral diseases. So, this is part two, where we're going to move on from the assessment phase. And now that we've gathered all of these beautiful assessments, what do we do? What is the next step in this journey? And so today's program is going to focus on those diagnostics. And more specifically, my goal for this two-part series is to help empower the clinician, particularly in the hygiene department, but I know that we've got doctors here and practice administrators and amazing office team members here joining us. My goal is to help us all understand how to better calibrate ourselves so that when we see these clinical assessments come out of the hygiene exam, when we see these periodontal assessments, these radiologic images, etc., when we see these modalities come out, what do we do with that information? And more specifically, how do we communicate that to our patients? I think a lot of times when we look at programmatic content that's focused around empowering our patients in knowledge and understanding the level of disease they have in their mouth, one of the biggest challenges that we see in dentistry is the fact that we're talking about an overtly prevalent disease process. So, this is a repeat slide from last time. I want to reorient everybody to what we're talking about and more specifically, the why around what we're talking about. We're going to be focusing on patients who are presenting with oral inflammatory conditions in the hygiene chair and getting back to the basics of how we foundationally identify these diseases and educate our patients about the serious nature of these diseases. So, one of the challenges that we see when we talk about oral inflammatory conditions is that this is an extremely prevalent disease. And I implore you to consider, if you take a look at the prevalences, that these diseases, as they're presenting in the average adult patient population, I want to be clear, this is your average adult patient population. So patients around the age of 30 and above. This prevalence breakdown is kind of a combo of multiple studies. So in 2016, the CPITN was an index that looked at the presence or prevalence of periodontitis across US adults. And it was noted that about 47.2% of our adult patients between the ages of 30 and 79 have some form of periodontitis. Now, we're going to look at the complexities of periodontitis today. And what we're really going to look at inside of these complexities is the fact that this does not necessarily mean that all 47% of these individuals have active periodontitis. You'll see in a minute when we look at the various striations of periodontitis that we will also see patients who are in a state of remission. I'm going to use that term quite a bit. Patients who have at one point in their lives had the activity of periodontitis, and through some kind of means, they've been able to resolve that periodontal condition. So now they're in a state of remission. So that's going to comprise about 47%. That's almost 1 in 2 of our adult patients who walk in and out of our doors. Then we take a look at the remaining patient population. So the individuals who do not already have periodontitis, either in its active or remissive form. And when you take a look at that remaining patient population, the statistic there is a bit more murky because we're using a gingival index score. That's a low in stillness score. So when you take a look at the remaining patient population, about 94% of those individuals have inflammation in their mouth. So to be clear, that's going to comprise the remaining almost half of our patients. About 94% of them have some form of inflammation. But to be specific, 55% of those individuals have a gingival index over 1, meaning they have generalized moderate to severe gingivitis. So I want you to know, when we take a look at the prevalence breakdown here, 47% of our patient population, our adult patient population, are going to be considered a periodontal case, whether active or in remission. About 28% of our patients are going to present with generalized moderate to severe gingivitis, which shouldn't be lost on any of us, is the precursor to periodontitis and is actually the number one risk factor for periodontitis. Pervasive and overt inflammation over a long spectrum of time is the number one risk factor for the patient graduating from gingivitis into periodontitis. And to be very clear, we're talking about moderate to severe cases that fall into this category, which means that about 25% of our patients, that remaining patient population, about 25% of those individuals, and there are decimal numbers here, it's actually 25.2%, but 25% on average of our adult patients are either considered healthy or have incipient or mild gingivitis, as outlined by the AAP. So if you take a look at this breakdown, this is a good indicator for practices. If you actually take a look at the percentage of your adult patients who are being treated with a 4000s procedural code, meaning they're receiving SRP or they're in that 4910 periodontal maintenance, versus the number of adult patients who will likely be appropriate candidates for that D4346, the scaling in the presence of gingival inflammation, versus the patients who are going to be considered appropriate for a preventive procedural code. That would be your prophylaxis, right? Your D1110. So I encourage you, practice owners, administrative team members, hygienists who want to better understand how their diagnostics stand up to the prevalences of disease. Take a survey of the patients in your practice. How many of these patients are receiving these periodontal codes? How many of these patients are being treated with that D4346? And how many are receiving a prophy? You could even look at your hygiene column, hygienists, and identify if I have a full day, 8 patients back to back, and every single one of them is a prophylaxis that day, then my hope is that when we go to the next day, that we see a significant amount of perio or gingivally diseased patients receiving the appropriate procedural code. Unfortunately, I think we can all agree, and I would imagine your ACT dental coaches, for those of you who work with the amazing ACT dental team, can probably agree that unfortunately we don't see these numbers often in practices. Meaning, we do not oftentimes see that about 3/4 of our adult patients are receiving an active therapeutic / maintenance code, and then 1 in 4 of our adult patients are receiving a prophy. We usually see the inverse. And again, I think most of your ACT dental coaches can probably agree. Usually we see the inverse, where I actually think it would be great if 1 in 4 of our adult patients were receiving some kind of a perio code. But even that number, for a lot of consultants, 25% of adult patients in a general practice receiving perio therapy, even that number sometimes can be seen as considerably high for a perio percentage. So there are a lot of disparities in here. It's important to call out that there's a high likeliness that in your practice, there are patients walking in and out of your doors every day that present with some layer of disease. And yet those patients are asking for the free cleaning their insurance covers. When they're asking for that free cleaning their insurance covers, they're assuming that they don't have an activity of the disease process, and therefore they qualify for that healthy category. And so that creates the complicated layer. Again, and this is a slide that I presented during part 1. But I want to remind all of you that a large portion of your patients who are presenting for a routine cleaning are highly likely individuals where periodontal treatment is going to need to be proposed to those individuals. And the challenge is those are the patients that are presenting into that hygiene column every 3, 4, or 6 months. So they're on the hamster wheel, the recare system in the practice, which makes it very easy for the patient to blame the clinician for the presence of their disease. Patients will say things like, well, I was just in 3 months ago. So did you not give me a good cleaning last time when I was in 3 months ago? Never mind the fact that the patient just added one new medication, increased the dosage of another medication, is currently going through testing right now because they're pre-diabetic, and they aren't actually using the toothbrush that you encourage them to use for 2 minutes twice a day along that gingival margin with the Bass method, right? So the reality is, while for our patients, they are looking at the fact that this disease process, periodontal disease and gingivitis, is oftentimes asymptomatic. And I'm putting that in quotes because the reality is we know that gingival diseases are actually not asymptomatic. There is bleeding that occurs. There's halitosis that occurs. There's redness of that gingival margin that occurs. However, the patient's body does a beautiful job of shutting off pain receptors. The patient's body does a beautiful job of saying, we're not going to cause pain until this moves into a very severe area. And so, for the average patient, if they're not experiencing any pain and you start telling them that you have active infection in your mouth and we need to have this treatment done and it's going to cost you out of pocket to have it done, and by the way, your insurance may or may not actually cover it because that's a big question mark, then your patient's going to be upset. The concerns about how do you help your patient understand that we are detecting or identifying a disease process. The good news is we caught it early. The good news is we caught it in an earlier state of the disease process. And so the treatment now is going to be far more non-invasive. It's never going to be cheaper, easier, or more pain-free to treat than it is right now. How do you color that picture? How do you bridge the gap with patients who've been coming in expecting their free cleaning that their insurance covers? You do the assessments, you identify that there are problematic localized areas. This is a oftentimes slow moving, but still progressive disease process. It would be amazing if our patients came in, sat down in our chairs, pointed to their upper right quadrant and said, you know what, Angela, I'm noticing some bleeding in my upper right quadrant, and my husband noticed that I have bad breath. I think I need a 4342 over there. Wouldn't that be amazing if our patients actually asked for the treatment that they need? Well, I have to tell you this funny story. My sister is a foot and ankle surgeon. Many of you have probably seen my sister and I co-present together. She's a podiatrist. She sees a lot of patients who present to her clinic with diabetic foot ulcers. Now, the patient does not know that it's a diabetic foot ulcer when they present in her chair. She looks at it, she knows right away that's a diabetic foot ulcer. The patient oftentimes has not been diagnosed with diabetes until they're sitting in her chair. She looks at it, she identifies the condition, and she says, we need to do some advanced testing. We need to get to the root cause of what is creating your ulcer on your foot. She does the testing, she comes out the other side, and she says to the patient, you're diabetic, and that is why you've experienced this issue. Well, interestingly enough, diabetics have a complication called diabetic neuropathy, which is a condition where their nerve endings won't necessarily pick up on pain reception. And so, one of the challenges with diabetics is they can be walking on their bare feet, step on a Lego, and not even know that they stepped on that Lego. And so, they can create or experience trauma because those pain receptors have shut down. So the patients that present to my sister's chair, my sister's operatory, aren't even necessarily experiencing pain. Get this, and this just, it's going to blow your mind. I asked my sister one time on a podcast recording, I asked her, what is it that brings your patients in? You say they're diabetic, they don't know they're diabetic, so they're not necessarily getting care from an endocrinologist who's referring the patient over, and their feet aren't hurting them because they've got that neuropathy. So what brings your patients in to your chair to say, Doc, I got a problem with my foot? And she goes, oh, that's really easy. When they take their shoes and socks off at night, there's blood in their sock, and they think that's weird and concerning. They think that their feet should not be bleeding. So when they see constant blood in their sock, they think I should probably call a foot doctor. Can you imagine dentistry? If every time our patients bled, they called somebody who was, I don't know, an oral healthcare specialist. Like, can you imagine? We would be so slammed. We wouldn't have time to sit on webinars, right? So the concept here being, for whatever reason, patients are concerned about an extremity at the other end of the body bleeding, but a hole in their skull that is just inches from the brain and inches from the heart muscle that is bleeding, for whatever reason, our patients tend to think that is completely normal. Alongside that, we also reviewed 2 weeks ago that one of the biggest reasons, the biggest drivers or challenges or complications around why patients decline their specifically periodontal treatment plans. And this has been done, this initial study was done by our friends at Aura Pharma. It has subsequently been replicated by our friends at Pearl. The number one reason when patients are surveyed about why they declined their periodontal care plan, patients who have received a comprehensive care plan for SRPs, local delivery of antibiotics, custom perio trays, whatever it is, the number one reason why they decline their treatment plan is because they actually do not trust their dental health care professional, which is crazy, Because for us, I think that dentistry, unfortunately, is at the other end of the pendulum. And this is just me, Katrina Sanders, based on my study, 2 decades now of observing the provisions of dental care, doing the research around what CDT codes are billed to the ADA every year. I believe that dentistry is on the other side of the spectrum, where it takes quite a bit for us to finally tell the patient, you have disease and we need to do something about it. As you're going to see in a minute, I think that a decent portion of dental practices will, in fact, wait until the patient gets into at least stage 2 periodontitis before they will actually talk to the patient about the disease in their mouth. Even at stage 1 periodontitis, I believe a decent portion of dental practices are fearful about graduating or elevating that patient into performing therapeutic care. So by the time a dental professional actually says something to a patient, says this is an area of concern and we need to move forward, more often than not, that disease process has progressed a lot further than we would like it to. Why do we wait until the patient moves into stage 2 disease? Because at stage 2 disease, there's a greater likeliness that the insurance company will probably cover it. That's why. Because stage 2 periodontal disease, as you're going to find out throughout today's program, stage 2 periodontal disease is where we finally hit that 5 millimeter probing depth, which we know, bingo, is going to be the green light for a decent portion of third-party payers. So we're waiting to tell our patients about an irreversible disease process until we feel confident that their insurance company will probably reimburse for it. We wait to tell our patients about this irreversible disease process that is linked to, has a biological plausibility that it is an exacerbative modality, accelerating upwards of 57 unique diseases and conditions systemically, like stroke, heart disease, upper respiratory tract infections, diabetes, adverse pregnancy outcomes, and certain types of cancers. We will wait until we feel confident and comfortable that there's a high likeliness that the insurance company will pay for it. And even still, we will give our patient a bare bones treatment plan. Here's 4 quads of SRP. Let's just start there. Let's just start there, is what many of us say. And then we'll reevaluate and see what you look like and see how you heal. When dentistry are we going to start looking at the complexity of our patients and say, Mr. Jones, I'm concerned you have stage 2 periodontitis. And at this stage 2 periodontitis, it's going to be even more complex than it was in stage 1 to treat it. If we don't treat it now, it's not a matter of if, it's a matter of when. That stage 2 periodontal condition is going to accelerate to a stage 3 periodontal condition. I've yet to see a single research study that indicates that a patient can floss their way out of an irreversible disease process. I have yet to see a single research study that says if we use the F word and tell them to just go ahead and floss better and we'll check you out in 3 more months. I've yet to see a research study that says that that flossing habit, that by the way, your patient for many decades has never done, and all of a sudden now you think that you've reformed that patient and they're going to go ahead and start flossing. They're going to be the world's best flosser. I don't mean to say that that never happens, but let's be honest, dentistry, it would be a Christmas miracle if all of our patients paid attention to our recommendations and followed them. The challenge that we see across the United States in dental practices is that despite our patients knowing that toothbrushing habits, interdental care, knowing that many of their medications do in fact cause dry mouth or could accelerate inflammation in their mouth, knowing that our patients are coming in and sitting down in our chairs and receiving routine screenings and evaluations and still question our authority, our understanding of the complexities of this disease process. This, for me, as a periodontal hygienist, is the essence of what I believe is holding dentistry back from moving all of our patients who are entrusting us with their care to as close to 100% health as possible. And that's our goal, isn't it? That's our goal. We talk about production goals all the time. As a clinical hygienist, when they talk about production goals, I don't listen because respectfully, I believe that if you do the right thing, the production will always follow. And the reality is, if we get back to the essence of what we need to do in educating our patients about the complexity of the disease process and explaining to our patients what that disease process means in a way that is meaningful for them, we help to empower our patients with the right knowledge for them to make a decision, true informed consent, giving our patients the autonomy to decide the level of care they wish to receive. Because we are, in many ways, robbing our patients of autonomy if we decide that we're not going to recommend care until their insurance company might cover it. Respectfully, you have patients in your practice right now who are watching family members suffer from Alzheimer's disease. Respectfully, you have patients in your practice who have family members who are suffering from cardiovascular disease. You have patients in your practice who are suffering with infertility complications. And a decent portion of those patients would do a lot, would pay a lot to help prevent their infertility issues, to help prevent their potential Alzheimer's disease down the road, to help prevent a potential cardiovascular event from happening. So, dentistry, the empowerment that we have now is in understanding how incredibly important and valuable our work is. Today, we're going to be deep diving into that, looking at the complexities of how we can better educate our patients on the why. My name is Katrina Sanders, and it is an honor to be here today alongside the amazing folks at AAP Dental. It is such an honor to work with them every time that I go back to Wisconsin, which, by the way, is where I'm from. I'm from a small suburb of Milwaukee, southeastern Milwaukee. Kirk and I have like the same life story, truly. And every time I go back to Milwaukee and I get to spend time with the amazing folks at AAP Dental, I am just delighted, and it feels like I never left. And so it means so much to me to be here. And I want to thank so much the amazing team at AAP Dental for always rolling out the red carpet for me to work alongside them. I'm also going to be delivering some programmatic content today from our friends at BioGaia, closest Procter & Gamble, and Paradise Dental Technologies. This is a continuation from part one, where we're going to be looking at the role of innovation in periodontics. And yes, we dove into some of the technologies and therapies last time. Today, we're going to be diving into how we take those digital imaging diagnostic tools, AI-assisted diagnostics, and really leverage that to help communicate to our patients now the what and the why. So today we're going to be really implementing this by looking at critical diagnostics. So without further ado, buckle up, buttercups, as we dive into the complexities of periodiagnostics. I'm going to give you just a short disclaimer here. There are many speakers who present on periodontal diagnostics, the AAP staging and grading. And I will tell you that I do not expect that after you take this with this program today that you are going to be an expert in AAP staging and grading. And in fact, I'll tell you, as somebody who has spoken at the American Academy of Periodontology annual session meeting for the past 2 years, and have actually listened to the folks who developed the staging and grading piece, they agree that the staging and grading is actually not a precise and exact science. I'm going to say something particularly for the dental hygienists on the call today. And I hope that you will take this from a loving matter, because I am a dental hygienist as well. Something happens when you give particularly a dental hygienist a grid or a sheet that has very hard lines on it and says the patient belongs in either this category or this category. Hygienists just want to put the patient into the right box, and we want to be right. Oh my gosh, we want to be so right. We want to go, yep, this is a stage 2 grade B, right? Did I do it? Did I do it? Did I do it right? Doctor, did you do it? And the reality is, when we talk about conditions on a chronic disease, we're talking about a continuum. Oftentimes, our patients are lifelong patients of our practice, or we've been seeing them for 10, 15, 20 plus years in our practices. So there's an ebb and a flow to how these diagnostics happen. Patients will enter and then remiss in this disease process. And I will share, as a periodontal hygienist, I certainly see a stronger share of patients who are consistently towing that line of re-entering back into the activity of disease and then stabilizing. And then we've got a couple of areas where we're reactivating that disease and now we're stabilizing again. And I think sometimes we want to grab a diagnosis and we want to stick with it. And the reality is, it's going to move. It's going to move because our patients, the complexity of our patients, are going to move. So be patient with yourself as we walk through these staging and grading modalities. Okay. So here's the framework for the staging and grading piece, right? For those of you who have seen staging and grading, you maybe have not seen this piece. Not all speakers share this. I want to share this because when we talk about staging and grading, we're only going to be talking about this area right here, plain Jane periodontitis. But it's important to know that there are all these other different kinds of complexities to the disease process, the health process, and then various kinds of conditions that will affect or impact the periodontium. Now, unfortunately, I don't have time today to walk through each and every one of these. That's like a oftentimes multi-day workshop to actually hit every single one of these. But it's important for me that you know that patients can present with, for example, an endoperio lesion. So a patient could be all 323s. That's every dental hygienist's favorite number, right? 323. Followed shortly there by 212. We love that number too. But we could have a 323 patient, 323, 323, 323, 323. I'm doing the numbers on the keypad, right? 323, 323, 323. And then all of a sudden we're probing the patient. It's like 3212. And it just slides in that one pocket. And it's like, whoa, what's going on? You take a PA of the area, you see an endo problem, and it's like, oh gosh, right? So in a patient case like that, that patient doesn't necessarily have, we're not going to stage and grade that patient. That patient has an endoperio lesion just in that one localized area. Everything else is stable, right? So I want to be very clear. There are other contributory factors that can cause advanced probing depths. Traumatic occlusal forces is another good identifier. So sometimes patients can have traumatic occlusion that can accelerate clinical attachment loss. So some patients can have recession, but that recession isn't actually due to periodontitis. It could be due to some other condition that's going to affect the periodontium. In perio, we see patients, for example, who come in to be evaluated for lower anterior tissue grafting. And I'll see these new patients. I see doctors' new patient consults, which is kind of fun. So I'll see this patient. We'll do all the assessments, take the images, radio, all the stuff, right? Orient the patient. Hello, you're here to have your lower anteriors evaluated. Is that sensitive? We do the whole thing, right? And when I peel down that lower lip, I can see in some cases why that patient has recession down there. Some patients, actually a decent portion of patients who have lower anterior recession on that direct facial, have a very high frenal attachment. So that abherent frenal pull over time has accelerated or created that clinical attachment loss in that thin gingival tissue area. So there are other kinds of mucogingival deformities or conditions of the mucogingival apparatus that can give clinical attachment loss. That it doesn't necessarily mean because that patient has a high frontal pull that the attachment loss is because of perio. We have to look at etiology. And I will say, folks in the perio space spend a lot of time going back to etiology. To go back to my sister, Dr. Sanders, if all she did was say, oh, yeah, that looks like a weird ulcer, let's put some ointment on it. I'm so sorry. Some people don't like the word moist. Ointment is that word for me. Woo. But we'll put some salve or some cream on it. We'll give you some antibiotics and we'll send you out the door. No, my sister does advanced testing and says, ooh, this ulcer is because of diabetes. So we're going to get back to that root cause. We have to address your diabetes. Of course, we're going to do wound care for your foot wound, but we've got to address that root cause. In perio, we spend a lot of time looking at that root cause. Where did this come from and why? Because if I'm going to repair it, rather, my doctor is going to repair it. If my doctor is going to repair it, we need to make sure this isn't going to come back and become an overt or invasive issue. A few other things to look at inside of this. So when we talk about periodontal health, it's important to know that we have a new, I'm not going to say category, but a new area that we need to focus on in dentistry. And I'm going to be sharing that with you in just a short minute. That's periodontal health and then the term of gingival health. So stay tuned. We're going to talk about that because this is actually new. And as a dental hygienist, as a perio hygienist, I love that we've got these complexities now that we can explain to our patients. Then we've got two different forms of gingival diseases or gingivitis. The first one is your dental biofilm-induced gingivitis. The second is non-biofilm induced. We'll talk about those complexities in a minute. Then, of course, we're going to move over to good old periodontitis. And in this category, we can have necrotizing diseases. So many of us remember the term ANUG or ANUP, acute necrotizing ulcerative gingivitis or acute necrotizing ulcerative periodontitis. So fun fact, they got rid of the A. So it's no longer acute, even though we know that it's quite acute. And these necrotizing diseases are going to include NUG or NUP. Then we've got our good old plain Jane chronic periodontitis. And again, this is where we're going to stage and grade the patient. Then we have this other category here called periodontitis as a, keyword here, manifestation of systemic disease. Patients in this category will present with a systemic disease, and the AAP has listed them out. I think there are like 12 or 14 of them. These conditions are very, very, very specific conditions where periodontal disease is a manifestation or a symptom of that disease. Put simply, if you have this kind of systemic disease, any one of these 12 or 14 systemic diseases, you will have perio. And these are quite obscure diseases. They're things like Papillon-Lefebvre and Chidak-Higashi and histiocytosis and familial and cyclic neutropenias. They're quite obscure diseases. They are oftentimes genetic disorders. So like Chidak-Higashi, for example, you will see very young people, like pediatric teeth with recession. Like how often do you see pediatric teeth with recession? Not often. But when you do, it's like, this is not right. Why are we seeing this? You should have a very robust immune system, a very stable attachment apparatus around your pedo teeth until, of course, we're exfoliating them. What's going on? Little kiddo gets tested and it turns out they have Chidak-Higashi. So the fact that the patient has this systemic condition means they will get periodontitis. Okay. And again, these are very obscure diseases that have been published. Glycogen storage disease, all Ehlers-Danlos. So very specific diseases. I want to share that because you'll see over here, not to confuse everybody, but periodontists sometimes like to confuse people. I can say that lovingly because I work with periodontists. Not to confuse you, but we've got this guy over here, systemic diseases or conditions affecting the periodontal supporting tissues. I know they sound like the same thing because they both have the term systemic disease in them, but they're different. And here's why. You'll notice that this falls into the category of other conditions affecting the periodontium. Okay. So systemic diseases, or I'm going to have another sip of my coffee here. Systemic diseases or conditions affecting the periodontal supporting tissues means that these are patients that have any one of, or could have a combo of systemic conditions where we know that that systemic condition will affect the periodontium, could affect the periodontium. So some of those examples could be diabetes, could be HIV, could be rheumatoid arthritis. So we know that if our patients have some of these immunocompromised or malnourished complications, it's not like they will have periodontal disease, but it certainly does mean that that systemic condition could affect the periodontium. So those patients are going to kind of fall into this category. Put simply, it helps us to identify contributory factors. What could contribute to this condition, this periodontal condition, becoming accelerated? What are those contributory factors? And then again, we have other conditions that we looked at. So perio abscesses or endoperio lesions. We could have mucogingival deformities and conditions. That is a whole course in and of itself. Traumatic occlusal forces. So again, primary or secondary occlusal trauma, we know can accelerate clinical attachment loss. And then we even have this thing called tooth and prosthesis related factors. So that is a category that talks about things that I will say, as a periodontal hygienist, I spend a lot of time with. And I don't think the average general practice knows that they're spending a lot of time with. The number of times, hygienists, that you get into a fight with an enamel pearl and don't win is a lot more frequent than you think it is. The cool thing about working in perio is I'll be working in a closed flap situation and I'll whine enough and my doctor will come over and cut that flap open for me to look at it. It's like, oh my gosh, this piece of calculus that I thought I've been fighting with is actually just an enamel pearl. Well, if the patient has an enamel pearl, or another big one, we spend a lot of time here on the maxillary lateral incisors on the palatal aspect. Some patients anatomically will have a palatal lingual groove or a deep invagination just anatomically to the tooth. That is just their natural tooth anatomy. But my goodness, we spend a lot of time in perio trying to clean that out for a lot of our patients. Because if you have a deep palatal lingual groove, that's a tooth-related factor that is going to be plaque retentive. That could mean that the patient could be more prone to a periodontal condition down the road. So I wanted to give an overview of all of these different kinds of conditions. Let's walk through the more common kinds of conditions that you will see. And that begins by looking at the spectrum of clinical health. Now, when we talk about clinically healthy patients, I think most of us, when we envision that in our mind, like if you close your eyes and you picture what a healthy patient looks like, I'm a perio hygienist, so I'm going to need some of you to tell me what that looks like because I don't see that a lot. But clinically gingivally healthy on an intact periodontium is what most of us picture. Okay. So that means an intact periodontium. No clinical attachment loss, no recession, no bone loss. That is an intact periodontium. And then clinically gingivally healthy indicates that this is a patient where the gingiva is healthy. So again, if you picture that beautiful bone, beautiful stability of the periodontium, and the gingiva is healthy. That's what a lot of us picture in our head. Now, my question to you is, and again, I just have to ask this as a perio hygienist, how often do you actually see that, right? The statistics indicate that that's, 25% or less of our patients that are going to fit into that category. Now, we will also have patients who are considered the gingiva is clinically healthy. Okay, so I want you to picture that. The gingiva is clinically healthy. Coral pink tissues, stippling, tight, contours of the gingival margin around the neck of the tooth apparatus or implant apparati. So clinically, the gingiva is healthy, but the patient has a reduced periodontium. So I want you to think about that. With that reduced periodontium, that could mean bone loss radiologically. That could also mean just clinical attachment loss that we're detecting clinically, right? So that could be recession. And there are two major reasons why a patient would fall into this category. The first is the obvious one that most of us clinicians are thinking about already. That is your stable perio patient. Okay. So that's a patient who at some point in their life had active periodontitis. They received active periotherapy. And after that active periotherapy, they came out the other side. They're in a state of remission. And that state of remission now means that the gum tissue is clinically stable, but the destruction has already happened. Our goal now is what? We want to keep that patient in a state of stability. We don't want to see an additional acceleration. And we know this, but it's important for me to just say this out loud so I can hear myself say this. These are patients that are also at risk for resurgence of periodontitis. So these are patients that we keep on a short leash. These are patients that we keep on a short recare system because the concern is that we're going to see a repopulation of this bacteria and we'll see a reactivation of that disease process. These are patients who are prone. Okay. Conversely, we can also have patients where they have that reduced periodontium and the gingiva is clinically healthy, but they do not have a history of periodontitis. So that kind of opens the door to remind us in dentistry that there are reasons why a patient could have recession or have exposure of that root surface that actually are not induced by a bacterial infection, or rather the coordinated effort of periopathogenic bacteria in the oral cavity. And we're going to take a look at some of those patients together. So let's dive into the complexities of these cases. First, we're going to look at a patient who has an intact periodontium. Okay. And what I've done here is I've compared a healthy patient versus a gingivitis patient so that we can start to kind of compare clinically what are we looking at here. So in an intact periodontium, we will not see any attachment loss. Typically, in an intact periodontium, your probing depth in a healthy situation is going to be about 3 millimeters or less. Now, in a minute, we'll talk about gingivitis a bit more. It isn't lost on me that sometimes we can see these gingival cases where they will have an advanced probing depth, not because of a pocket depth, but because of a pseudo pocketing or gingival enlargement, right? So it's not lost on us that we can see that sometimes. The major difference that you're going to see between health and gingivitis is that bleeding upon probing. According to the AAP, a healthy patient can bleed 10% or less of the mouth, and that is considered still healthy. More than 10% of the mouth bleeding, that's where we start moving the patient into gingivitis. Okay. That's where we move that patient into gingivitis. And again, radiologically, we're not seeing any bone loss. The concern that we have is that the longer that the patient sits in a pervasive gingival inflammation condition, the greater the risk that patient will experience clinical attachment loss associated with periodontitis. Okay, next, we're going to look at a more common type of a case that we see. These are patients that have a reduced periodontium. So again, these are patients that have bone loss or have clinical attachment loss, and they have been successfully treated for their periodontal condition. Okay. So these are patients who have gone through active perio treatment. They've come out the other side and they're in a state of stability or remission. With these patients, will we see attachment loss? Yeah, because that is the irreversible nature of periodontitis. We will see attachment loss. We could see clinical attachment loss. We could even, in some cases, see that radiologic bone loss. Remember, we're talking about stable on a reduced periodontium. A few other things to note here. You will notice that in a healthy situation, stable on a reduced periodontium, that the probing depths here that would be considered acceptable will be 4 millimeters or less. Now, that's interesting. 4 millimeters or less. Here's the important piece. Not a single one of those 4 millimeters can bleed. If our patient in this category has 4 millimeter probing depths and they're bleeding, we're going to stage that patient and we're going to grade that patient. Okay. So we're towing the line now. The patient has attachment loss. So they are at a minimum going to fit into either periodontitis or a reduced periodontium not associated with perio. We do need to historically know the history for our patients, which can be a challenge. But in this category, If our patients have generalized 4 millimeters and none of them are bleeding, we're good. The moment those 4 millimeters start bleeding, that patient now has the activity of periodontitis once again. They've re-entered back into the activity of disease. Now, here's the other side of it, and this one's a bit tricky. The other side of this is looking at patients who maybe are coming in for your periodontal maintenance, that D4910. They're coming in for their perio maintenance. You're probing them. All probe depths are 1s, 2s, and 3s. However, we are getting a bleeding tendency. 10% or more of the mouth is bleeding. So I want to be very clear. Probing depths of 1 to 3 millimeters, but the gingiva is bleeding. At that point, the inflammation is localized to the soft tissue. It hasn't spread to the underlying attachment apparatus yet. So this patient would have that inflammatory condition, that inflammation on a reduced periodontium. Is this a patient that we should be concerned about? Absolutely. Because this is a patient that if we don't do something to address that gingival inflammatory condition now, we're going to have a big problem down the road. Because we know that the presence of bleeding upon probing, redness, swelling, that those are going to be good indicators to accelerate that patient back into the activity of the disease process. So our concern with a successfully treated perio case that has inflammation localized to the soft tissue is that we want to get on top of that immediately. We want to get on top of that immediately. I get asked all the time, Katrina, how often do you see patients for perio maintenance? And the answer is it depends. It really depends. If my patient is coming in every 4 months and they're presenting with inflammation, the probing depths are all 1s, 2s, and 3s, but they have generalized bleeding, 10% or more of the mouth is bleeding, I'm going to shorten that recare. I need to shorten that recare because if I don't, the patient's not a matter of if, matter of when, the patient's going to accelerate back into the activity of periodontitis once again. And the intention of a maintenance procedure is to maintain the patient where they are. So we have to be very careful about this. Now, the final piece in this category is looking at patients who have a reduced periodontium. So they have radiologic bone loss, possibly. They have clinical attachment loss of some kind. And these are non-periodontitis cases. So these dentistry are going to be our tricky cases. These are patients who will have clinical attachment loss for some other iatrogenic reason. It is not associated with the sequelae or etiology of periodontitis. We'll look at a couple of examples, but one of my favorite examples to give is a patient who's gone through crown lengthening. So a patient who's gone through crown lengthening may have had areas of their tooth structure surgically exposed. So when you see recession in those areas, or you see some clinical attachment loss in those areas, that clinical attachment loss is due to a history of crown lengthening, not due to a history of perio. I'm going to show you another really good example in a minute that I hope will help to kind of color that picture for you a little bit more. But it's important for me that you know that we absolutely can have patients who have that reduced periodontium, but that reduced periodontium is not associated with perio. And again, in these categories, you can have a healthy patient. That healthy patient will have, probing depths of 3 millimeters or less. And notice that bleeding tendency, less than 10% of the mouth. That'd be considered a healthy patient. Conversely, we can see a patient who will have gingivitis on that reduced periodontium. And it's important to know that just because they have gingivitis on that reduced periodontium doesn't mean that this patient is at an increased risk for perio. So I want to be very clear about that. When we talked about our perio patient, our successfully treated perio patient who has inflammation, we're concerned because this is going to accelerate that patient's periodontal condition. However, a patient who's a non-periodontitis, just because they have gingival inflammation, doesn't necessarily mean that we need to be panicking about it. We do need to treat their gingival inflammation, but it doesn't mean that they are at an increased risk for periodontitis over a gingivitis patient who does not have a reduced periodontium. So let's take a look at some of these cases. This is all well and dandy while we're just talking about it hypothetically. What I want to do is show this to you in practice so that you can actually see what some of these cases might look like. So let's do a little review of what a healthy periodontium looks like. Now, clinically, the gingiva will be considered healthy when we see those gingival observations of a coral pink tissue. Again, tight attachment around the neck of the tooth or implant apparatus. We could see some incipient gingivitis or that localized redness. So we could see some incipient gingivitis. Remember, this is going to comprise about 25% of our patient cases. Probing depths 1 to 3 millimeters. And again, the major difference between healthy and gingivitis is going to be that bleeding tendency. So healthy is going to comprise 0 to 10% of the sites in the mouth bleeding. 10 to 30% of sites bleeding will denote incipient or localized gingivitis. And again, because we have that intact periodontium, we're going to see a stable gingival margin, no furcations, no mobility, no radiologic defects, etc. So here's a decent example of what this looks like. Please forgive me again as a periodontal hygienist. I don't have a lot of cases in my patient, body population that I can pull that are good examples of a patient who's clinically healthy on an intact periodontium. So this is a decent example. Clinically, a few things to note. Patient presents with generalized 1 to 3 millimeter probing depths, 10% bleeding tendency. Patient does not have recession. And this patient presents with a history of orthodontics. They come in every 6 to 8 months for routine prophylactic procedures. So the question here is, if the patient has generalized 1 to 3 millimeter probing depths, a 10% bleeding tendency, no recession, that patient would be considered clinically healthy on an intact periodontium. Is a prophy every 6 to 8 months appropriate for this patient? If you're nodding and saying, yeah, seems like they're able to well maintain their periodontium at a 6 to 8 month recare, you'd be right. Not every patient needs to come in every 6 months. That's just something that was determined by the insurance companies. But if this patient wanted to come in every 8 months and they well maintained their periodontium like this, absolutely. You can come in every 8 months. Some people can come in one time a year for their hygiene visit and they're able to well maintain their periodontium. They have a strong epithelial attachment. They have amazing genetics. They have a gorgeous immune system. They have all of those things, which is the reason why I married my husband, HIPAA, but he's got gorgeous gum tissues. I'm just saying in my defense, he has gorgeous gum tissues. So some people, like my husband, are blessed with a gorgeous biotype. They have amazing genetics. They have an amazing immune system. So my husband could go a year or more. He doesn't, but he could go a year or longer between prophies and have a gorgeous intact periodontium. That's amazing for that patient, but that's not every single one of our patients. And we know that to be the case. Now, we can also have a stable patient on that reduced periodontium. So now we're talking about reduced periodontium where we might see some areas of recession. Maybe there's a furcation exposure, particularly if our patient has occlusal trauma or history of clinical crown lengthening around those posterior molars, right? So we could see furcation exposure. My hope is that we don't see mobility. It would be a bit rare. With occlusal trauma, we could see fremitus, but that wouldn't be true mobility associated with periodontitis, right? And then radiologically, we may see some signs of radiologic bone loss. But again, if we're talking about a stable patient, their probing depths are 1 to 3 millimeters, and less than 10% of sites in the mouth will bleed. And again, this is a patient who has no history of perio or periotherapy. So a good example of this could be a patient who presents with generalized 1 to 3 millimeter probing depths where they have some localized sites of recession. The example I'm showing here is of a patient who has recession on that lower anterior lingual area. Teeth numbers 24 and 25 have about 4 millimeters of recession. You can see the patient has a history of ortho with that lingual bar cemented in. And if we dive a little bit more into the history of this patient, they have a history of oral piercing. Okay. Do you all remember when everybody had tongue piercings? It seemed like hygienists, especially, we're all going to go, oh, yeah, I remember that era when patients would come in, they have that tongue ring, the metal tongue ring with like the ball, and hygienists, what did we do with those patients? We would tell them, well, if you keep wearing this metal jewelry, it could chip your teeth. Right. It could rub down on the, inside area of your gums there, and it can cause gum recession that can be really sensitive. Right. So I think we did a pretty good job of educating patients about not getting tongue rings or taking their tongue rings out. Like, good job, dentistry. We did a great job there. The challenge is that for the patients that didn't follow our instructions, they're all now in my perio office having their lower anteriors extracted because they have so much clinical attachment loss. And now they're getting implant supported bridges down there. And all I mean to say, I don't mean to laugh about it, but I do mean to say that with patients like this, we do know that they can have clinical attachment loss in this case because of oral piercing rubbing on that area, creating tissue trauma that has accelerated. There's very thin bone in the lower anterior area, very thin tissue in the lower anterior area. And as a super side note, it is a pain in the butt in perio to try to do a tissue graft in the lingual area of the lower anteriors. It is very challenging to get that graft to stick. So this is a patient who would be considered stable on a reduced periodontium, but they are a non-periodontitis patient. And again, that's because the recession in this case is not because of perio. Now, this patient comes in every 6 to 8 months for routine prophylactic procedures. Is this patient an acceptable every 6 to 8 month patient? Well, clinically, if the gingiva is remaining stable, generalized 1 to 3 millimeters, very minimal bleeding, localized recession from a history of tongue piercing that they've since removed, that patient is considered stable. So, yes, we can continue to see this patient every 6 to 8 months. Now, conversely, let's take a look at a situation where a patient has a history of active periodontal therapy. So, this is a patient who's considered stable on a reduced periodontium. This is a successfully treated perio case. Now, with these patients, gingivally, they are clinically healthy. So the gingiva is going to have coral pink, maybe a couple of localized areas of some edema and erythema, but for the most part, this patient clinically looks really nice. Now, it's important to know in some of these areas that we will see the history of destruction. We will see things like perhaps tooth loss because of a history of perio in the past. We might see radiologic bone loss. We might see recession. We might see exposure of furcations. Hopefully, we've stabilized that mobility. The idea here being probing depths should be 1 to 3 millimeters. We can have a 4 millimeter probing depth, remember. But remember that 4 millimeter probing depth can't bleed. If it does, now we're going to stage and grade those cases. So we can look at some of these cases and identify that patient is considered stable on a reduced periodontium. This is a successfully treated perio case. And this patient clinically might look different. So if your patients look anything like mine when they're in perio maintenance, this image here is a good example of the kinds of perio maintenance cases that we will typically see in a perio office. You will notice here the amount of root exposure. You will notice the open embrasure spaces. You will notice that there is an incredible amount of surface area that I, as the treating hygienist, need to run my curettes across. That's important. There is a lot more anatomy, a lot more surface area that will be plaque retentive in these cases. And these are patients that, because they have a history of perio, they are prone or elevated risk for a potential periodontal complication down the road. So we want to make sure that we keep this patient in as stable of a condition as possible. So let's say this patient presents with generalized 1 to 3 millimeter probing depths. They do have some 4 millimeter probings, but none of those 4 millimeters bleed. And they've got generalized 1 to 4 millimeters of recession kind of throughout the mouth, depending on the area. They even have some grade 1 furcations. If you look at the patient history, they have a history of scaling and root planing about a decade ago, and they've been coming in every 3 to 4 months for their maintenance appointments. The question here is every 3 to 4 months an appropriate maintenance for this patient? Well, if you're considering the fact that this patient is considered a stable case, then the reality is, yes, that patient coming in on that every 3 to 4 month recare system works for that patient, as long as we can keep them in that state of stability. Now, here's the other side of it, or rather the other concern that we have with cases like that. What happens when we start to see gingivitis on that reduced periodontium? This is a successfully treated periodontal case. Now, even though we're seeing 1 to 3 millimeter probing depths, those areas, more than 10% of the mouth, now is going to bleed. This is an area of concern. This is a patient who is now on the, pun intended, on the cusp of re-entering back into the activity of the disease process. Let's take a look at an example case here. So clinically, if we take a look at this case, you can see that the patient presents with areas of clinical attachment loss. If we look at the clinical assessments on this patient case, the patient presents with generalized 1 to 3 millimeter probing depths. The patient clinically presents with a 50% bleeding tendency. And they have generalized 1 to 4 millimeters of recession throughout the mouth, kind of depending on the areas that we're looking at, with grade 1 furcations. This same patient also has a history of scaling and root planing about a decade ago. However, when we take a look at this patient's clinical display, I think we can all agree clinically, this is a different kind of patient. Clinically, this is a patient who has a history of perio, who's presenting with 1 to 3 millimeter probing depths. So the probing depths look the same between both of these perio maintenance cases, right? However, this patient that we're looking at right now presents with a 50% bleeding tendency. Okay, that's a different kind of patient. We're not seeing gorgeous coral pink tissue. We're not seeing a tight clinical attachment apparatus around the neck of the tooth. Here, we are seeing fire engine red tissue. We're seeing capillary invasion, redness, gingival enlargement, rolling of the gingiva, and of course, bleeding tendency. So now the question here is, we're seeing this patient every 3 to 4 months. Does that work in this patient's case? I'd implore you to consider that 4 months is probably not going to work for this patient. That at a minimum, we need to keep this patient on 3 months until we can control this inflammation. I also implore you to consider that once we start seeing these bleeding tendencies pop up, now we need to start thinking more complex. Now we need to start thinking about soft tissue management. Now we need to start thinking about what tools, adjuvant or adjunctive services, what things, steps, strategies are we going to do? Because this is a different patient. This is a different perio maintenance patient than the previous patient we looked at. This is a patient who's in distress. This is a patient who's just demonstrating complexities of that early disease process. They haven't quite re-entered back into active periodontitis quite yet, but my goodness, they are close. So one of the things that we need to really consider when we're approaching care with patients like this is the fact that we need to make sure that we are effectively selecting instruments that are going to help us to perform the task at hand. Particularly when we talk about perio maintenance, and it really is incredible, the confusion around, for example, a prophylaxis procedure versus a perio maintenance. Although we believe we know the difference, the reality is it becomes very difficult in a lot of practices to maintain and understand the difference between a prophy and a perio maintenance when it comes to the clinical application. If you ask an average dental professional, what's the difference between a prophy and a perio maintenance? The average dental professional will tell you a perio maintenance is when a patient has a history of perio. What they won't say are things like, A perio maintenance patient means that they have more exposure, more anatomy, that I have to be far more targeted. I have to clinically focus a lot more on where I'm going to adapt certain instruments. I am performing site specific scaling and root planing that is embedded into that periodontal maintenance procedural narrative. I need to perform site specific root planing in certain areas to make sure that we're targeting and addressing this disease process. And so I do want to share that our friends at PDT have done a beautiful job of building procedure specific instrument kits that have actually been selected for clinicians. So each of these kits, this one is the periodontal maintenance debridement kit from PDT. These instruments have been selected because of the amount of work that the average clinician needs to do during a periodontal maintenance procedure. That QR code will take you directly to the PDT page where you can look at all of their hygiene kits, by the way, and they're all labeled out, which I absolutely love. What they did was they took hand scaling experts and they said, we want you to build the dream kit for a periodontal maintenance procedure. We want you to build the dream kit for a scaling and root planing procedure. We want you to build the dream kit for a D4346 scaling the presence of gingival inflammation. And we want these kits to take into account or consideration what anatomy is the clinician adapting into, what kinds of challenging or complexing conditions might a patient with this condition have? And ultimately, what does the condition of the tissue look like? So, do we need to adapt into, for example, narrow interproximal areas where we need to be able to get a fine adapted or curved instrument into those areas? Do we, for example, and so I'm pointing here to the Nebraska 128 with the Langer on the other end. Um, do we need, for example, the Queen of Hearts, which is a gorgeous universal periodontal curette that has 6 millimeters of working end, which gives the average clinician an incredible opportunity to adapt into posterior areas. This is also designed, by the way, for patients who cannot open very wide. So some of these instruments have been designed or have a lot of complexities in bends, extended reaches, or mini cutting edges or mini blades to the
Okay.
instrument itself so as to be able to adapt appropriately into the areas
Yeah.
where the patient
I'll
is
see you in a
going to
few
need to have
hours.
advanced. I'm going to go ahead and mute you there. Yep. Thank you very much. So we're talking about areas where we need to be able to adapt advanced instruments into these areas. So this is your periodontal maintenance kit from our friends at PDT. Hygienists are salivating looking at this. I know you are. Why? Because when we're performing these advanced maintenance procedures, we need equipment to allow us to adapt into those areas. And with this combination of self-angulated, that's what we see with our Gracies, the self-angulateds, as well as some of our more universals, like your Barnhart, your Queen of Hearts, and who doesn't love a Montana Jack, right? That's like every hygienist's favorite instrument. On a side note, I love that they put the pink Montana Jack in here, not only because I love the color pink, but also because a portion of the proceeds of the purchase of the pink Montana Jack goes back for breast cancer research. The Queen of Hearts, a portion of the proceeds from the purchase of the Queen of Hearts goes back to the American Heart Association for cardiovascular disease research. So I love this. I love that they include these instruments in these kits. If for no other reason, number one, the fact that they are amazing for adapting into these areas, and then subsequently, number two, because they give back. So feel free to check out their amazing kits here by utilizing that QR code, and you'll see this QR code again in a minute when we look at their gingival inflammation kits. Let's take a look at gingivitis. Now, gingivitis is a complexity of the disease process that involves some kind of inflammation. We call it a non-specific inflammatory condition because we have two major flavors of gingivitis. The first is going to be your dental biofilm induced. Hygienists, this is our favorite. We love dental biofilm induced because that means the patient has biofilm everywhere, and we get to be the heroes by talking to our patients about appropriate toothbrushing procedures, or we get to be the heroes for our patients by talking about, appropriate, scaling in our chair. When we remove all that calculus and we remove all that materia alba and plaque, we are essentially helping that condition. The other condition, this one's a bit more challenging, is the non-biofilm induced. These are going to be cases where you'll perform a debridement on the patient and the patient won't respond, which means that their inflammation is coming from somewhere else. Now remember, my sister, the foot and ankle surgeon, is so focused on etiology. I'm not just going to treat your foot ulcer and then send you out the door. I want to find out where that foot ulcer came from. So step one is we need to treat that foot ulcer. Step two is we need to find out where did that foot ulcer come from. When it comes to gingivitis, the same is true. If we can eradicate that biofilm-induced gingivitis, we can treat that gingival condition and see the patient resolve. Excellent. But if the patient does not resolve, we need to consider, do we need to be doing advanced testing? Is there something else going on in this case? I'll say twice in my clinical career, I won't name them, but I remember the patient's first name in both scenarios. Both times I saw the patient come in, they presented with inflammation. I performed the D4346, the scaling in the presence of gingival inflammation procedural code on the patient. Patient came back 2 weeks later and they looked exactly the same. I compared my intraoral photos from the 4346 appointment to the re-eval, and the patient looked exactly the same. They did not respond. In both of those scenarios, I told the patient they needed to go to their physician and get blood work done. I instruct the patient to get a CBC done and a standard nutrition panel. In both scenarios, the patient came back and said, "You were right. Something wasn't right." Both patients were HIV positive. So we can see conditions of the tissue that are not necessarily related to biofilm, could be related to something else. So our burden in dentistry is that we need to understand this disease process, and we need to be able to appropriately educate our patients on what we're seeing. Gingivitis is considered the mildest form of periodontal disease. This is when gum tissues get red, swollen, they bleed easily. And I like to let my patients know that there is usually little or no discomfort at this stage. In fact, gingivitis, we know, is going to be reversible with appropriate treatment and good home care. The biggest identifier for gingivitis is a case of gingival inflammation as well as a case of bleeding tendency. And so this is really what we're talking about. When we see a patient, for example, who's presenting with gingival bleeding, you'll notice again that periodontal health is considered less than 10% of the mouth being affected. Then your incipient gingivitis or your localized gingivitis will be about 10 to 30% bleeding upon probing. Once we get to 30% or more of the mouth that is bleeding, that is considered generalized gingivitis. And from there, we'll classify a patient as mild, moderate, or severe, depending on the changes to the tissue, the observation of color, contour, texture, consistency, enlargement, or on the severe side, we're even looking at how fast or rapid does that bleeding tendency occur. And the challenge is we have to start thinking about gingivitis as the true disease process that it is. When I was in hygiene school, if a patient had gingivitis, the only thing that I had available to me to do was a prophylaxis on my patients. So I, in my lizard brain, convinced myself that I was performing a prophy to prevent the gingivitis from going into periodontitis. That's what I convinced myself of. But the reality is, if a patient has gingivitis, they already have a disease process, albeit reversible, But this is a patient who already has a disease process in their mouth. And now we have tools and procedures available to effectively treat that disease. So let's look at some of the layers of gingivitis that we may in fact see in our patient populations. We could have a patient who presents with that generalized moderate to severe gingivitis on that intact periodontium. Again, when we talk about an intact periodontium, we're not seeing recession, we're not seeing furcations, no bone loss. That periodontium is intact. And that generalized moderate to severe gingivitis means that the patient is presenting with probing depths. They could have some pseudopocketing. The major driver here is that bleeding tendency of 30% or more of sites in the mouth. Clinically, a patient could present with generalized 1 to 3 millimeters. They could even have some 4 millimeter probing depths. In this image here of this patient, you can see some interdental papilla that certainly is demonstrating enlargement. Can you see that capillary involvement there? Oh my goodness. The body is sending blood to the area to try to fight the infection. And we can see that right now it's located to the soft tissue. It has not spread to the underlying clinical attachment apparatus. But we can see those areas of gingival enlargement or pseudopocketing. So that's where we can get some of those localized 4 millimeters. When we dive into the history of this patient case, we find out the patient has a vitamin C deficiency. They're going through puberty, and we're seeing this patient every 6 months on a prophylactic procedure. So the question now is a 6-month prophy appropriate for this patient? My hope is you're saying to yourself, no. Number one, this patient needs nutritional counseling because they have a vitamin C deficiency. Number two, they're going through puberty right now. I cannot control that patient's hormones. But we know that hormones plus biofilm is going to create an accelerative inflammatory condition. So we need to, at a minimum, shorten this recare, target this patient with active therapy that makes sense and better aligns with debriding that biofilm that's accelerating this disease process. On the other side, remember, we can see patients as well who would be a non-periodontitis patient, but they have that reduced periodontium. Remember, a non-perio patient with a reduced periodontium is describing a patient who has clinical attachment loss for some other reason. So they could have recession. They might have some areas of radiologic bone loss, maybe. But this is a patient who presents with gingivitis on that reduced periodontium. So clinically, in this case, we're talking about patients where they will probe generalized 1 to 3 millimeters. They might have some localized areas of pseudopocketing, and they're going to have some sites of clinical attachment loss. Your job now to identify the etiology is to look at what is the source? Where did that recession come from? And when we dive into this patient case a little bit, we can see that the patient has malocclusion. We can see that the patient has a crossbite and has repeated occlusal trauma. So in this scenario, if we're observing this patient clinically, I think we can all agree that there are some localized sites of recession. There's some root exposure in this case. And we can see crowding, we can see potential crossbite, we can see linguoversion of the maxilla. So we're seeing some orthodontic issues in this patient case. And we're seeing gingival inflammation. So if this patient was coming in every 6 to 8 months for prophies, my question to you is that appropriate for this patient case? Now, number one, we know that part of this is biofilm induced. Part of the correction of this is going to be to eradicate biofilm. But another part of the care plan for this patient might be correcting their malocclusion. And that might mean more than simply putting the patient into an occlusal guard. So again, from our friends at PDT, yes, they've put together a kit that is designed specifically for gingivally inflamed patients. And what I love about this kit is that you'll see a lot of these instruments that have been put into this kit have been specifically designed. Here you see the N1 scaler, which has an elongated spoon on it. You see versatility, the Jack B. Nimble, for example, and then you see a universal Columbia 1340. You're seeing a lot of instruments here that allow for versatility in adapting into areas where it is assumed that the tissue is enlarged. And so there's going to be some tissue distension where the clinician's going to need to maybe pull that tissue back without creating additional tissue tags or tissue trauma. That's what this instrument kit has been designed for. is to be able to adapt into those anatomical areas, to be able to get into these tight interproximal areas with crowded or rotated teeth, for example, allowing for great versatility of all of these instruments to be able to adapt into those areas without creating additional tissue trauma, which is a major complication in the healing process. So again, that QR code there will take you to the site where you can explore all of the instrument kits that have been put together by our friends at PDT. It is the holidays upon us. If you want to get that hygienist or hygienists something under the tree because he or she has been a very good hygienist this year, no hygienist is going to complain if you get them brand new, fabulous, gorgeous instrument kits with fabulously sharp instruments. I'll tell you that right now. If they are not impressed with that, they're crazy. Okay, moving on. One of the other important modalities that we do need to focus on once we start seeing patients demonstrating the signs, stages, or symptoms of disease is what are the things that we are going to do to empower that patient to take care of their gum health at home. I mentioned earlier, I have yet to see a patient floss their way out of an irreversible disease process. However, I have seen patients improve their self care when they have an inflammatory condition and reverse that inflammatory condition back to a state of health. So, this is really where we want to capture our patients. I don't mean to say if they're a perio patient, they need SRPs or a 4910, that we don't talk to them about home care because we know how valuable that is. However, it is important for us to know that these gingivally diseased patients, their involvement at home becomes so critical to the story. One of the ways that we've started to combat a lot of this in our practice is by sending our patients out with samples of the gum detoxify line from our friends at Crest. This is a stannous fluoride dense paste. And stannous fluoride is not new to dentistry, but this formulation of stannous fluoride is new-ish to dentistry in that this stannous fluoride does not stain. The stannous fluoride, however, has some amazing bioavailability. So the stannous fluoride in the gum detoxify line is both bactericidal, meaning it's going to kill bacteria, and it's bacteriostatic, meaning it's going to slow or retard the growth or development of plaque in the mouth. What's more, stannous fluoride also binds to the toxins that bacteria release. So we're killing the bacteria, but the bacteria can still leave behind toxins. And unfortunately, a deficiency that we see with a lot of toothpaste formulations is that they do not address those toxins that are left behind. Those toxins are the ones that continue to accelerate the disease process and keep that inflammatory process moving. So one of the things that you are going to see in a minute is that when patients are placed on stannous fluoride paste, we find an improvement in overall baseline health. We find a greater reduction in bleeding tendency. And get this, 68%, so almost 70% of patients who use this stannous fluoride paste will transition from gingivitis back to a state of generally healthy. So if we can get the patient using this paste, paste matters, particularly when we're talking about a gingivally diseased case. The other side of this is toothbrushing. And we know that our patient's ability to debride biofilm is going to be a critical narrative to the story. So we've looked at the research around oscillating rotating motion. This QR code here, by the way, is a gift to you. This will take you to a letter of medical necessity. So for patients who want to purchase an electric toothbrush, they can actually use their Flex spending account to do so and use this letter of medical necessity to get reimbursed for it from their Flex spending account. Why is it important to have a toothbrush that is appropriate for addressing your patient's periodontal condition? Because we've found that about 88% of patients who are placed on this Oral-B IO oscillating rotating motion brush are going to transition faster from a state of gingivitis to a state of healthy, particularly when compared with those who are using a manual brush or those using a sonic brush. We also found that with the use of technology, like the application from our friends at Oral-B, that patients are actually brushing longer with better anatomical coverage and significantly less pressure, which we know is a big concern. Fun fact, less than 6% of United States citizens use an electric toothbrush. Less than 6%. That's compared to 10% of Canadians, 15% of individuals who live in France, 24% of individuals who live in the UK, and 45% of people in Germany use an electric toothbrush. Less than 6% of US citizens use an electric toothbrush. Don't you feel like you're telling patients all the time to use an electric toothbrush? Don't you feel like you're constantly preaching how important this is? So it goes to show that even though we're talking to our patients about it, they oftentimes are not following our recommendations of using a toothbrush. So, why do we talk about oscillating rotating motion? If you know me, you know that the research is really important. And the data has shown time and again that oscillating rotating from our friends at Oral-B outperforms sonic motion brushes. And that has been seen time and again. So, again, when you see those transition numbers of patients using that Oral-B IO brush compared with a traditional oscillating rotating motion, compared with a sonic brush, compared with a manual brush, that the Oral-B IO dynamically outperforms, certainly outperforms manual, outperforms competitor sonic motion brushes, and will outperform even other oscillating rotating motion brushes. So, something to consider again on that home care side for our patients. All right. So we've talked about healthy, we've talked about gingivitis. We're going to round out our program today by looking at our patients who are going to step into the active periodontal situation. And the American Academy of Periodontology has issued us kind of a three-step process for identifying a patient who should be staged and graded. The first is the assessment phase. We walked through the assessment phase already together during part one. So we know how critically important it is for us to capture appropriate assessments. One of the most important pieces that we looked at during that assessment phase is the fact that there are some deficiencies with regard to relying on radiographs alone. We recognize that the human eyeball can see upwards of about 50 different kinds of shades of gray. And again, it is important to know that that would be an eyeball that can see different shades. Some people don't know different shades of red or different shades of pink. So there are some subjectivity concerns with regards to the human eye reading some of these complexities on these radiographs. So if we're going to rely on defining periodontitis simply based on the radiologic bone loss that we see, the AAP has corroborated that it's going to make it very difficult for us to identify mild and even moderate cases of the disease process. Put simply, we have to be able to look to the other assessments that we have available, like our clinical assessments, probing the patient, et cetera. And we dove into that beautifully in part one just a few weeks ago. Once we capture comprehensive assessments, the next step in this process is to look at is this a patient who has active disease? And if so, how do we stage, and you'll see in stage 3, how do we grade these patients? Okay, so let's take a look at staging. Staging is kind of awesome. I personally appreciate what the AAP did in building out this narrative, because staging moves us beyond that one-dimensional mild, moderate, severe into looking at the complexities of disease and saying, well, instead of you have mild, moderate, or severe, that inside of this, we can have different kinds of prognoses and complexities of the disease process. So, put simply, Mr. Jones, you have mild periodontitis. To a patient doesn't sound like it's deeply concerning. However, saying to the patient, Mr. Jones, you have stage 1 periodontitis and I'm concerned, helps to communicate the dimensions, the complexities of this patient. Many of you are probably thinking to yourself, that sounds like cancer. And in a way, you might be right. The AAP actually designed this staging piece to sound like other chronic diseases that our medical colleagues use. So in the oncology world, yes, they stage cancer, stage 1 through 4. And the more complex the disease process is, or the more complex that cancer is, the more areas of the body that the cancer has taken over, the higher the stage. The earlier, the more localized, the more controlled that condition is, the lower on the staging spectrum a cancer patient is. We also stage hypertension. So the idea here now is we now have a communication tool for our patients. Stage 1, periodontitis, is considered the borderland between gingivitis and periodontitis. And unfortunately, the images here don't color the picture as well as I would like. It's important for me that you know that the clinical attachment loss, the breakage of those supracrestal fibers around the CEJ, are going to be about 1 to 2 millimeters, meaning we're going to probe this patient and we're going to probe past the CEJ about 1 to 2 millimeters. That is considered clinical attachment loss. Radiologically, if we do see bone loss, it's less than 15% of the coronal third, which is very minimal. And research has actually shown us it's almost nearly impossible for the human eye to detect that. Maximum probing depth anywhere in the mouth is 4 millimeters. And I want to be very clear, that is not 4 millimeters because of gingival enlargement. That is 4 millimeters because of downward movement of the probe. Okay. So we're talking about downward movement where the probe is moving past the CEJ and we're getting that 4 millimeters, probing depth, indicating 1 to 3 millimeters of a sulcus and then maybe 1 to 2 millimeters of that clinical attachment loss to give a total of that 4 millimeter probing depth. If we don't treat the patient in a stage 1, it's not a matter of if, it's a matter of when the patient will move into a stage 2. And in a stage 2 situation, this is where the AAP advises that we have an opportunity for clear intervention and subsequent monitoring. And again, I mentioned earlier, I think one of the most provocative challenges that we see in dentistry today is that the average dental office will probably wait until the patient moves into stage 2 to treat the patient, or at least to talk to the patient. Why? Because in a stage 2, maximum probing depth anywhere in the mouth is going to be 5 millimeters. Now, that interdental clinical attachment loss has moved. So now we are probing about 3 to 4 millimeters beyond the cemento enamel junction. That's your fixed point that we use. And radiologically, that bone loss is still in the coronal third. So, yes, one of the things that we discussed in part 1 is the fact that now the AAP has us take the root and split it into thirds. And so we're looking at where does the bone level fall within the thirds? Is it in the coronal third, the middle third, or the apical third of that root surface? So, yes, taking PAs is an important part of identifying periodontitis. Yes. So here at stage 2, this is our opportunity to provide an intervention. If we don't provide an intervention at stage 2, it's not a matter of if, it's a matter of when. The patient will move into stage 3. And here in stage 3, we are looking at a more or deeper complexity of the disease process. In stage 3, the AAP defines this as deep lesions that extend into the middle third of the root and beyond. The management of this case is going to be a lot more complicated, a lot more anatomy exposure, a lot more furcation exposure. We could have vertical or angular defects. We could have ridge defects. And I will say, for those of you, and I would imagine there's a decent portion of you on the call today who probably treat patients with this condition in a closed flap scenario. So you're not flapping these cases to actually see what these ridge defects look like. But as a periodontal hygienist who does these flap cases, it's important to know that in these scenarios, when you actually look at the bone, when everything's flapped open and you see a stage 3 case, you can see that destructive bony pattern. It is extremely inconsistent. Bone loss does not happen consistently. It is inconsistent. It is up and down. And the contouring and the architecture there makes that management very complex. You have exposed anatomy everywhere, and you have a lot of extra work to do. So, one of the things that our friends at PDT have done is, you guessed it, designed a gorgeous kit. This is the debridement kit for our patients who need active periodontal therapy. So yes, this is the non-surgical scaling and root planing kit. You will notice here that the instruments in this kit, again, have been hand designed, pun intended, because they're hand scalers. They've been hand designed for this kit because of their adaptability. You will see that we've got some gorgeous extended reach curettes, and these extended reach curettes are going to allow for comfortable adaptation and appropriate bends to be able to get and adapt around line angles without creating that tissue distension. That's the area of concern that we run into with SRP. The other thing too is when you take a look at instruments like that Queen of Hearts, the Queen of Hearts really sparkles and shines when you're trying to adapt it into a furcation area because of how long and curved that periodontal curette is. It reminds me of a McCall's 1718. For those of you who love using that McCall's on that distal aspect of a molar, doing that horizontal stroke and moving it around. But the Queen of Hearts was designed by a dental hygienist, by Susan Wingrove, who is a hygienist. This was designed because she recognized that we needed to have patients close down halfway so that we could get onto that posterior area. And we wanted to have a shorter shank, but more room with that curette. So again, our friends at PDT have really come through with this gorgeous kit, again, designed for clinicians who are actively treating a lot of these advanced anatomical cases. Now, I know what you're asking, Katrina, but what about stage 4? You're right. We do have stage 4. The only difference between a stage 3 and a stage 4 is that in a stage 4 situation, the patient has or will lose 5 or more teeth due to the periodontal disease process. So, in a stage 4 situation, we see the complexities of stage 3. We see the advanced radiologic bone loss into the middle third of the root and beyond. But now the patient's prognosis has declined. The disease has spread so deeply that now we're amputating teeth, literally amputating teeth, body parts, because of how diseased this is. To go back to my sister, Dr. Sanders, and the work that she does, if that diabetic foot ulcer continues to spread, if she can't control that condition, she's amputating pieces of that patient's foot. She's amputating, which is going to now affect that patient's condition. It's going to affect their ability to walk. The same is true in a stage 4. When we amputate enough teeth, it affects the patient's ability to chew. And what it does is it's now going to apply stressors to the remaining teeth, who probably are also experiencing a periodontal condition that we're trying to preserve. So we're trying to, put implants in and preserve some of that masticatory dysfunction in this scenario. In a stage 4, the patient remains a stage 4 for life. All right, let's move on to the final step in the AAP staging and grading modality, and that is establishing the grade. For every patient who's identified as active periodontitis, which we now know is a true 4 millimeter pocket, not tissue enlargement or overgrowth, but a true at least 4 millimeter pocket where we're getting clinical attachment loss past the CEJ. In these scenarios, the patient is bleeding, the patient has probing depths. Sometimes we can see radiologic bone loss, maybe not. Once we've identified the patient as active periodontitis, they will receive a stage and they will receive a grade. Now, grading is new in dentistry. And grading is new because in the past, we didn't really have a way of identifying what the progression of the patient's disease process was. But essentially, grading is looking into a crystal ball and predicting what the future risk of periodontal disease progression is. We're also predicting how effective will our care be for this patient? How effective will our care be? And the grade also tells us how much of an impact does the patient's periodontal condition have on their systemic health. Now, we grade things in the medical world. Tumors are given a grade. A rapid grade tumor is a tumor that is growing very fast. The last time assessments were taken on that tumor, it was smaller. Over a short period of time, the tumor has grown very fast. That is a rapid rate tumor or a fast grade tumor condition. Some tumors are slow grade or low grade tumors where they're not growing that much. So with a rapid rate or aggressive grade tumor, that clinician is in the oncology world going to be more aggressive with their care. They might have to actually remove more healthy tissue. They might have to do mastectomies or removing organs and, putting the patient in a colostomy bag, things like that. There's a lot more catastrophic stuff that happens, and we need to be more aggressive. If it's a low grade tumor, maybe we don't need to be as aggressive. Maybe we can try a more non invasive approach first and observe. So the grade on the healthcare side drives a lot of how that disease shows up, because we know that periodontal disease, for example, doesn't show up the same way in all of our patients. So a critical aspect for us is not simply identifying the stage 1 through 4, but also looking at how fast is this disease process showing up in your case. And that's where we move into the concept of grading periodontitis. Again, we kind of grade these progressions like they do in the medical space. So, grade A is a slow progression, grade B is a moderate progression, and grade C is going to be your rapid rate of disease. And some of this is going to make sense. First, we want to be able to look at direct evidence. We want to be able to say, has the patient had no radiologic bone loss or clinical attachment loss over the past 5 years? Have they had some, but it's been moderate? Or have we seen rapid progression, 2 or more millimeters of clinical attachment loss or radiologic bone loss, right, over the past 5 years? That would indicate rapid rate or very fast rate of progression. Sometimes we have that evidence. Sometimes we don't. Sometimes we don't. So we need to look at indirect evidence sometimes. And this is where we'll look at things like, how much bone loss does the patient have based on their age? Is this a 90-year-old with 30% bone loss, or is this a 15-year-old with 30% bone loss? Both have 30% bone loss. One is extremely young, and that's extremely concerning, right? We can also look at case phenotype. So, how does the body respond in the presence of biofilm? In a grade A, that patient can have tons of biofilm everywhere, and the body doesn't really have that exaggerated of a response, which means good for you. You have an amazing immune system. The body is at least keeping this under control. We're not seeing an exaggerated response. On the other side, in a rapid situation, that patient could have, and I see this quite a bit in our perio office, that patient could actually have very minimal biofilm. As much as I love to joke about our patients not following our directions and not using the electric toothbrush and all of those things, it is important to know in my perio office, there's a large portion of patients that do follow our recommendations to the T. They are brushing multiple times a day. They're using multiple interdental aids. They are doing everything they can, and still the destruction in their mouth exceeds the small, tiny, minuscule amount of biofilm they have in their mouth, which means they have an exaggerated response, which means their immune system isn't fighting as readily. The host response is just in a panic mode and in a constant state of panic. Right now, we also have 2 grade modifiers. The first is tobacco habit. So, depending on the patient's tobacco status, a non smoker, half a pack a day, or more than half a pack a day, we can predict that their tobacco status may give an atypical host response. And we also look at diabetic conditions. So, a patient who is a non diabetic would be considered a grade A or slow rate. A diabetic patient whose A1C is under 7% would be a moderate rate. And then, of course, over 7% HbA1c is considered a rapid rate, which means that these 2 conditions are tobacco status and diabetes are going to drive the potential display of these risk factors. Why do I bring that up? Because when we talk about treatment planning based on the grade for the patient, those risk factors or the progression, the rate of progression of disease should be an indicator to inform the treating clinician. Number one, if we don't see improvement, what are we going to do about these cases? If the patient has a high grade of disease, what other things are we going to do to be aggressive in this case? Do we need to do a referral to the patient's physician? Remember, an advanced grade indicates that their periodontal condition is now likely dramatically impacting their systemic health. How do we treatment plan moving forward so that we can help drive patient compliance? And how intensive does the maintenance therapy need to be in these cases? So, I want to kind of round out with one final tool that I want to give you before we wrap up today's course. And that is looking at how we can help to leverage a strong immune system for our patients. When we have a patient with an advanced grade of the disease process, it is a good indicator that their immune system needs some additional support. And one of the best ways that I've found that we in dentistry can support our patients with that is by recommending that our patients take dental specific probiotics. This QR code here will take you to a page where you can connect with the wonderful team of BioGaia, the makers of ProDentis, which is a line of probiotics designed for teeth and gum health. This QR code will also take you to the site where you can not only connect with them, but also request samples for your patients. Now, we've heard about probiotics for gut health, right? And some of us might have even heard about probiotics for colic health or bone health. Yes, there are even probiotics for oral health. And we've found that these probiotics, these are bacteria that are health producing in the mouth designed for oral health give some incredible benefits. So, when we compare patients who have not been given probiotics from our friends at BioGaia versus patients who have, in fact, received probiotics, we find that the probiotic group experiences things like reduction in bleeding tendency, reduction in periodontal pocket depths, a clinical attachment gain of 54% when compared with individuals who are not on probiotics. We also find that these health producing bacteria starve out your periodontal pathogens. So you are reducing your Prevotella intermedia, Porphyromonas gingivalis, and Aggregatibacter actinomycetum comitans by upwards of 90%. You are also reducing the inflammatory markers. So we see lower tumor necrosis factor alpha, interleukin 1, interleukin 7 in the crevicular fluid. These probiotics actually really sparkle and shine, particularly when a patient has advanced probing depths. So we find in perio that when a patient has a probing depth of 7 millimeters or greater, that we see amazing efficacy. And this is one of my favorite things about these probiotics. It significantly reduces the amount of bone loss or the acceleration of that bone loss in periodontal patients. Now, there are several different kinds of probiotics, oral healthcare probiotics that are on the market. I want to tell you why the probiotics from BioGaia are currently the ones that we work with and why. So, there's a strain specificity to probiotics. Not all probiotics are the same. Probiotics will have different kinds of bacteria in them. So, the TheraBreath line, for example, has active strains of a bacteria called K12 and a bacteria called M18. Active strains, for example, in Probiera are going to be Strep oralis, Strep ubris, and Strep rattus. So these particular kinds of Strep and salivarius. So these types of bacteria, albeit health producing, when we look at clinical trials that have been issued by the American Academy of Periodontology, and I encourage you to consider reading this paper, it's a great paper. On the clinical relevance side, the American Academy of Periodontology says that as a generalization, probiotics actually do not move the needle at all for our patients, unless you are talking about bacterial preparations that contain Limoselactobacillus rhodori. L. rhodori is the bacteria that is in the ProDentis line. In fact, there are two strains of L. rhodori, and these are health producing bacteria that we've found they are of human origin. And so these bacteria have been heavily studied. And the American Academy of Periodontology came back from their meta analysis saying any probiotics that contain L. rhodori are going to be good for oral health. So again, we need to take a look. Just because there are oral care probiotics does not necessarily mean that they are going to be statistically significant or give us a demonstration in improved periodontal probing depth scores. So it really is those probiotics that contain L. reuteri, which again are friends at BioGaia with the ProDentis line via this QR code here can provide. So, with that, I want to thank all of you so very much for joining me and the amazing ACT Dental team today as we dove into some of the opportunities to leverage a precise mode of communication, using staging and grading to help our patients understand the complexities of their disease, while also using that information to leverage appropriate treatment modalities to educate our patients. And ultimately, using that information to identify what kind of adjuvant or adjunctive services are going to make sense so that we're designing or building a patient-centric care plan instead of treating all patients based on an average standard. As my Christmas present to all of you, I'm giving this QR code here. This QR code will take you to a registration page for a free webinar. That free webinar is going to go over the updates to the 2025 ADA CDT codes. So it's going to walk through all the information that you need to know to start off 2025 with a bang. With that, I'm going to turn the microphone back over to Angela and the amazing team of ACT Dental. Looks like we have a couple of minutes left for questions. I apologize for running over a bit here. I know we won't be able to get to all of them. But Angela, I wanted to go ahead and give you the microphone back.
Thank you. Thank you. Thank you for everything. I just love all of this information. It's such a good reinforcement. Thank you.
Thank
And
you.
you're right. We have a couple minutes left. We want to make sure everybody gets out on time today, but I've seen some questions in the chat I think we can answer. Going back to the beginning, Tom had a question about legally, how do we deal with patients with active periodontal disease who flat out refuse periodontal treatment?
Fabulous question. So I'm going to answer this question because Tom used the word legally at the beginning. So the first thing I'll say is I'm not an attorney. So you certainly, from a legal standpoint, I would encourage you to explore your state practice act in your state at the dental board, et cetera, all of those things. Okay, now that we've gotten that out of the way, from a legal standpoint, an informed refusal form holds no water in a court of law. So if you're talking legally, you're in a court, an informed refusal form is not going to hold any weight, which means even if you have a piece of paper that says, well, the patient knew and they refused it, so I did the pro fee anyways, it's always going to come back to, but you're the provider who knows better, right? So you should have done something more. So, how do we deal with a patient on the legal side? I will tell you, you're not going to be well protected if you continue to choose to do a prophylaxis on those patients, which I think is what you're asking, Tom. So, I want to be very clear. You do have a couple of options with that patient. You can refuse to treat that patient. And I know that sounds really scary, particularly if you're a business owner or a practice owner. Ooh, you don't want to tell that patient, well, then we can't treat you. You need to go somewhere else. But I encourage you to consider that there's power in that. There's power in saying to the patient, we cannot provide the level of care that you're looking for. So we would encourage you to find a practice that will. Here in this office, we deliver care based on standards of excellence. Another thing you can do is say, would you be open to getting a second opinion? I understand that you're not interested here. Would you be open to a second opinion? Because if you go to the periodontist and get a second opinion and that periodontist says, you can go ahead and manage this patient with just a regular cleaning, then you know what? I feel comfortable doing that regular cleaning on you. Would you be open to going and getting a referral to the periodontist? Leverage your referral source to help. The third piece of advice that I'm going to give you is to consider referring that patient to a dental hygiene or a dental school. It's one of my favorite tools to use because oftentimes, not always, but oftentimes it's financial in nature. So letting the patient know you can actually have this done for free, or in some cases, the students will pay you to be a patient to address your periodontal condition. But if you're not going to get this care done by me, please let somebody do it. Typically, for the average reasonable patient, that tells the patient, oh my gosh, this really is serious. They don't even want to collect my money. It's that serious.
You always have such great responses.
Thank you.
This is kind of a 2 or 3 part question, but I'm gonna hit the one that probably most people are wanting help with verbiage wise. From Annie, it says, and how do you explain to a patient why a prophy and perio maintenance feel the same and take the same amount of time, but have such big cost difference?
Fabulous question. Oh gosh, that's so hard, isn't it? So a few things. Number one, I think this is part of the biggest challenges that we run into in dentistry. We don't even fully know the difference. And again, one of the challenges that we see is a decent portion of patients who are receiving a perio maintenance technically are being billed for a prophy. There's still offices across the United States that will alternate a prophy and a perio maintenance with a patient. It doesn't mean that they got a prophy at one appointment and then a perio maintenance at the next one. We're still going all the way down to the base of the pocket beyond the CEJ no matter what. So, how do you explain the difference to the patient and why? Number one, when we're doing perio maintenances, we're screening for additional things versus a prophy. In a prophy, you should not be tracking things like recession. You should not be tracking furcations. You should not be tracking mobility. But in a perio maintenance, you are. You should be examining where those furcations are and you need to adapt to those areas. Perio maintenance also permits you to do site specific scaling and root planing. So I let my patient know there are some areas where I need to do site specific root planing in those areas. Bear with me. I'm going to show you where those areas are because those are the areas that I need you to focus with your brush and your interdental care aids. And so I'm actually walking through what I'm doing during a periodontal maintenance, helping my patient understand. The good news is we can do site specific root planing during this procedure. I have different kits that I use for a prophy and a perio maintenance. So my patients know that I'm adapting with different instruments into different areas of the mouth. I'm oftentimes taking additional imaging of certain areas. I want to get the full length of the root of the tooth or the full length of the implant in a lot of these areas. So my patient is actively seeing an entire screening process and subsequent activation as dynamically different. And the reality is, our folks in the medical space do that all the time. A patient who has a history of breast cancer and is now in remission needs to go in. They'll get the same mammogram. They'll get hooked up to the same mammogram equipment that a non-cancer history patient will. They'll have the same level of screening done. However, a breast cancer survivor, that's going to be an individual, for example, who will need to be screened far more routinely and talking about risk factors and all of those things. So my hope is that we fully understand the major differences and that we're able to explain to the patient what comprises a remission patient from a healthy patient because they are different. I think we've answered the questions here. Thank you all so much for the love and the support here. Heather, I think you're going to wrap things up, sister.
I sure am. Yes, Ange had a hard stop. Thanks everybody for attending our masterclass today. And a huge applause and thank you to you, Katrina. I have like 4 pages of notes. I appreciate it so much. And I don't know for the people that were looking at the chat, as a clinical hygienist myself, I'm sitting here kicking myself because hindsight's always 2020. But something else that you have shared in other amazing courses that you've provided is that once you know better, do better.
That's
So
right.
it's our opportunity to show up better for our patients. And we often care so much about our patients that we'll just do that prophy. Here's my challenge to you guys as a coach at ACT. You care so much about your patients. Do not let them walk out that door without letting them know their true condition, and take the information that Katrina's provided to help you to build your confidence in doing so.
That's right. Oh, very well said, Heather.
Yeah. Well, Katrina, you're amazing. Thank you again. And I'm
Yes.
sure
Happy
that
holidays to
Ange
everybody.
yeah, I'm sure that Ange will secure you for some time next year as well.
Of course. Of course. Happy to do it. Thank you all so much. Happy holidays to all of you and your families, and cheers.
Same. Thanks, Katrina. Thanks, everybody.